Righto, so I'm a registered nurse by trade, which means I spent about 20 years working in the emergency room of hospitals in Melbourne and Adelaide in Australia. And then I did a PhD, and the PhD was looking at men's experiences of prostate cancer. And I moved across to UBC at that point, and I've been at UBC for 6 years. And I've done a postdoc education there around psychosocial cancer issues. So my main focus is on patient experiences. I'm not probably the guy who's going to find the cure for prostate cancer, but I hope to be one of the people that help men on their journey and also their families on the journey that can be pretty diverse and pretty challenging with prostate cancer. I acknowledge that in the room, in speaking to groups, there is huge diversity here. So a couple of new fellas who might be thinking about treatment decisions. We might have some long-term members, I'm sure, who have seen and heard it all over 5 or 10 years at least. And so what I present to you tonight will not reflect everybody's experience, but I'm putting forward some ideas based on having spoken to 25 fellows who were on active surveillance. So I want to make that clear, and I don't mean to contest any experiences that you may have had yourself, but really just to open up a dialogue. I don't mind if I chalk and talk you for 30 minutes here, but I really welcome interruptions in the form of questions, in the form of dialogue and comments to help sort of make some of this content a little bit more meaningful as we move along. Need to acknowledge a couple of people. Joyce Davison is from the Prostate Centre in Vancouver, who works with Larry Goldenberg there, who you may know of, a urologist working out of Vancouver. Tom Pickles is a radiation oncologist, and Larry Moroz is a guy I think you're going to hear a fair bit about in the future. He's a dietitian who's doing work in prostate cancer, and he's just finishing off his PhD. So those three people were part of the study in helping me put together the study and conduct the study. I want to locate men's health behaviours in the notion of active surveillance. So I don't want to just talk about active surveillance. I want to think about men's health behaviours, what we say about men's health behaviours. So often we'll say that men are reactive rather than proactive. So typically a man will wait longer, he'll monitor symptoms of ill health longer, eventually talk to a spouse, and then reluctantly see a doctor. That's typically what we hear about. We also know that fellas don't typically talk to other men about their problems in terms of illness or health. In fact, guys are a little bit suspect if they know about health or start talking about health in certain environments. Certainly, you know, when you're playing golf or at the pub or whatever you might be doing, typically guys don't really engage with that kind of discussion. So we also say that men take enormous risks with their health, especially young men. So the amount of accidents, amount of alcohol-related incidences that we see that fellas really do die younger, and we seem to lose guys to preventable things. I'll come back to this, and I know it doesn't feel incredibly relevant as you get older, but there's some things to think about within this profile that help us think about active surveillance. Prostate cancer, like, it's often put forward in ways that are humorous. We often talk about the idea of people brokering us being screened for prostate cancer. In fact, there was an article yesterday that talked about if you have a wife, you're 40% more likely to go and get screened for prostate cancer. So we know that men's uptake of PSA and digital rectal examinations has always been much lower in comparison to the screening that women undergo. There's a few reasons for that. Not the least of which is that culturally we don't expect men to be going to the doctor. We tend to think of men as being okay, waiting for symptoms to arrive and then going. Active surveillance. There's a difference between active surveillance and watchful waiting. So it's an emergent treatment or non-treatment action. And so the idea is that we would do PSA blood tests at regular intervals, and that we would monitor them from a baseline every 6 or 12 months in a man who has an established prostate cancer. So he will have had a Gleason or a transrectal ultrasound biopsy and a Gleason score. So he will have a diagnosis. And then the idea would be that we wouldn't necessarily go straight into a treatment decision, but that we would continue to monitor the PSA level over time. And the goal of that is that you reduce the amount of treatments of indolent cancers, cancers that might not go on to be major problems, and you decrease the side effects of invasive treatments. So we know that there's a lot of challenges around erectile dysfunction, around urinary incontinence. So it's a way of delaying treatment. So it's a delay with curative intent. So the notion being that you wait, but you don't wait so long as you can't be treated. So it's a holding pattern of sorts. It's useful in T1 and T2, so in those early stages where we know that the cancer is confined to the gland, it's an option. It is an option. That said, we also know that many men don't take this option up. And we'll talk about that as we go on. But in the States at the moment, of the people who are eligible for active surveillance, less than 10% are going on to active surveillance. Still a sizable population, and as time goes on and more urologists and more treatment specialists are talking about this as an option, I think we'll find those numbers may increase. The previous research around active surveillance, there isn't any really. There's very, very little. Most of it's talked about watchful waiting. And so what we know about watchful waiting is that men have incredible difficulty not doing anything. So watchful waiting, the notion was that there wasn't a whole lot of reason to treat the prostate cancer because another illness, a comorbidity, would likely end the person's life before the prostate cancer would. That old adage of die with rather than of. And so much of what we know about not doing anything in terms of an active treatment is based on that literature, which doesn't necessarily represent the men going on to active surveillance, who are a different clientele. That said, I'll share a little bit with you. We know that the doctor's opinion and the way they position the cancer with clients is incredibly important about the uptake of watchful waiting and active surveillance. We also know that when people decide to come off watchful waiting and want something else, want an active treatment, typically it's not about biomarkers or your PSA's rising. Typically it's about wanting to do something, being active within it. So I think we learnt a little bit from watchful waiting, but we didn't. We were interested to know what this notion of active surveillance would mean for men. Just a little bit about the design of the study. Most times when we think about research, we think about either cutting up mice or animals to get a notion around the cause or cure of prostate cancer, like the bench science. I think we often think about that as the gold standard. I don't disagree with that at all. Then we often think about these survey questionnaires where there'll be a set of questions and we'll get people to tick a box, and then we'll highlight relationships between anxiety and action. And that's a useful way as well to think about research. And when people talk to you about qualitative research, it's about talking with survivors, with people with prostate cancer, about their experiences. Oftentimes it's small in number, but the advantages of it is that you get a lot of data, you get a lot about the experience, and you're not confined to the questions you ask. Often it's conversation and you start to discover some things. I'm a fan of this because talking to people is usually you find out a lot more. I'll give you an example. In my PhD, the transrectal ultrasound with the biopsy, typically done, putting a probe into the anus of the man, shooting the needles through the wall of the rectum into the prostate gland to retrieve the specimens and test them under a microscope. Well, in Australia, when I was doing my study, there was no local anaesthetic given. There was no procedure in terms of pain. And these men were complaining of pain both in the 15-minute procedure and post that procedure for up to a week. So the residual pain was quite a significant issue. So we were able to change that by talking with the men and then putting forward the idea that lignocaine could be put into the margins of the gland to reduce the pain. And it's common practice. That is used in Vancouver, but things don't always transcend across different places. So by talking to men, you can actually find out a lot. So hence, my suggestion is that sometimes we don't know the questions that we should ask, and your experiences of prostate cancer are incredibly important in helping us, really thoughtfully consider how best to support people. The sample of 25 men, these guys, the average 68 years, they were married, Caucasian, post-secondary education. We have a cross-sectional view. Because it's an emergent kind of treatment option, we could only really talk to these guys once. We can follow up. But for this study, it was just the one time. Less than a year to greater than 2 years. So the majority of the men fell less than a year. So there was 13 of the 25 had been on this for less than a year. We need to keep that in mind. Their PSAs were typically less than 10 at the time to go on to active surveillance. Their Gleasons were also under 6. Okay, so there's a couple of biomarkers whereby they start with. And how did they get there? So I'm not presenting this portion of it in detail tonight, but I'd just say that what is absolutely key to any man going on active surveillance is a dialogue with his treating physician about the possibility of being on active surveillance. That's not new data. We know that when you see a urologist, most times they'll recommend a prostatectomy. There's studies to support that. And we know that the influence of the doctor is absolutely key to even considering this as an option. Uncertainty. It has a definition. There's an entire literature around uncertainty. It's a psychological stressor that can occur as a result of being unable to determine the meaning of an illness-related event and inability to predict outcomes accurately. And you can imagine being diagnosed with prostate cancer and then in the same notion not treating it, even though it was treatable. So it creates a certain amount of uncertainty for people. And that's key, that's a given. But the three sources of uncertainty that we found when we talked to the fellas about, what that uncertainty relates to, is that if you're being tested every 6 months with a PSA, then what happens if the cancer progresses within that 6 months and you go back in 6 months' time and it's escaped the gland, it's moved out? And what do you do then? So there's concern about that. There's concern about an imminent need for treatment. So if you go in and there starts to be a raise in the PSA, have a repeat biopsy, and then suddenly you are needing a treatment and you're needing it quickly, there's concerns about having to suddenly engage with that choice and feeling under enormous time pressure, which I'm sure is being experienced by other men. But for these guys, having to sort of work within those confines. And of course, that impending PSA, going back each 6 months, and it's sort of never quite getting past that. It gives you an extra 6 months and you feel good for 6 months, but then coming up to the date, raised anxiety. There's one fella said, it's a little scary. Every time I come up to my 6-month visit, I have a little bit of anxiety. And then we do the digital and everything is fine, and the PSA is fine, got another 6 months. So I sort of live 6 months at a time, basically. So as a fellow who's been on 15 months with the active surveillance. And I think it's important to sort of consider, the ways in which men cope with that. So if uncertainty is a given, then how do guys kind of deal with it? You're on active surveillance. What's the ways in which you can best get through that? So we found 2 patterns. 14 of the 25 fellows clearly were invested in living a normal life, and I'll talk about that in more detail in a moment. And 11 of the fellows were right into the other, almost the antithesis of that, doing something extra. So living a normal life, it's not a subject I talk about. I'm trying to get on with my life and just follow the doctor's directions and do what they prescribe, and talking about it to a lot of people only creates a kind of sympathy that I'm not really concerned about. So, when we talk about men's health behaviours, I can see something very typical here. I can see that this man is not going to talk about his illness. He's not going to be invested in having conversations. In fact, he's going to bracket the cancer as non-existent, even benign, as a way of coping with the uncertainty. There's a couple of things that were a little concerning around the pattern, because I'm not saying that it's a bad thing inherently or a good thing, but a lot of those guys didn't have the support of their spouse. In fact, we found that many of those fellows were defending a decision to be on active surveillance, and that was part of their stoicism. That was part of their lack of ability to really talk about it. There's also a bit of a misinterpretation about active surveillance, and that was that it might go away. The cancer might just disappear, because I don't actually have to do anything about it at the moment, therefore it may just go away by itself. And of course, the continuum of that is that the ultimate of bracketing a prostate cancer as not mattering or not needing my attention is that you stop going back for the 6-monthly or 12-monthly tests. And that's a concern, clearly, in a clinical practice where someone's got a prostate cancer, that you lose them to follow-up as their way of coping with the anxiety or the uncertainty that's created by going back into services. Barriers to further change. When we talk to these guys about, would you make subtle changes? They were reluctant to do that. And the reasons that they were reluctant to do it was because they had healthy lifestyles, and also there is no science that points to the cure or cause of prostate cancer. Therefore, what could you do that would be scientifically proven that would help you prolong your time on active surveillance? So kind of interesting ways of thinking about this. The guys who were committed to doing something extra. Interesting group of fellows. The youngest men in this cohort of 25, and these the two youngest men were at 46 years of age, highly invested in doing something extra. And a lot of it related back to couples. And so the main things that we saw were around ideas about diet, for instance, changing up diet. And so often that would be negotiated with partners at home, and the women were often a big part of that. There were things like meditation, there were things like exercise routines, and so personal trainers got employed. A lot of these guys started to do things that were hyper performance aspects. There's one fellow said, she's kind of into it a lot more healthy foods than I am. She's always jokes about how it's a work in progress to change my eating habits or whatever. I try to go along, but don't make it too dramatic. Over time, she's kind of slowly changed things. But this situation, prostate cancer, has caused us to hasten the process a little bit more. Relatedly, there seemed to be more of a sense that you're in the holding pattern and you definitely would proceed to a treatment at a later date. So as this fellow says, I think it gives me some comfort being on active surveillance. If I was just drifting along and not thinking there was some other possible alternative to the radical prostatectomy, then I would, it just makes me feel better that I'm looking for these alternatives and that they're coming along actually. So this guy's investing, some time in looking for alternative treatments as well. And also, some of the fellas positioned, the science of prostate cancer treatments advancing. So the longer they could wait, the more sophisticated the treatments would be. So if you end up looking at it schematically and a little diagram, you can sort of see the implications of being on active surveillance and this notion of self-management of the uncertainty that comes along with it. And just to give you a little bit more detail. Clearly it's a mind over matter situation for all of the guys. So they need to cope with having a prostate cancer that is amenable to treatment, that isn't being treated. And so the ways in which they do that become key to how we might support that in clinical practice. So in terms of living a normal life, and I'm really interested in your thoughts about this too, I suggest that we don't work to change the men to necessarily confront their cancer. I think that probably what we should do is work with the men and talk to them in terms of general health promotion. And the reason I say that is because if we talk to the men and say, you must confront this, you must be aware of this, then we risk raising their anxiety, we risk raising their uncertainty, and if our goal is to keep people on active surveillance for as long as we can, I don't think that it really helps us in a lot of ways. So I put that forward as an idea that we should be probably talking about exercise and diet in general terms and not necessarily locating it next to prostate cancer. Doing something extra, there's a myriad of options that are available on the internet in terms of ideas about how we might best cope with prostate cancer that aren't traditional biomedical models. And I think that guys who are doing something extra still need some guidance and some clear guidelines about how best to guide their efforts. And so while the science isn't there around diet, I do think we have some generic things to offer these men as well and their partners. And I don't think it's enough to have these guys coming back every 6 months and not supporting them in the interim and not giving them some information. So I think exercise is another key benefit. We know that men engage in exercise. It's one of the health promotion strategies that men truly have engaged with over the years. So I see that as a reasonable sort of thing to be talking about with the guys. I also wouldn't be positioning those information sessions around diet and around exercise. I would not be coupling them up with the time that the men come in for their PSA tests at the 6-month mark and 12-month mark. And the reason being is that I think there's significant barriers to hearing information because they're clearly most anxious and most uncertain as they're coming in for that PSA test. So I think we need to thoughtfully construct it that we stagger those information sessions for these men. So in the bottom of the schematic, the recommendations would be, I think there's scope for group-based active surveillance rehabilitation programs. I think that men who are committed to living a normal life might be more amenable to individual counselling and education. I think there's a significant need for dyad, as in couple interventions, where both parties are talked to, and I think that transcends both living a normal life and doing something extra. And I think ultimately our aim has always been with active surveillance is that people are calm in it, if you can be, but cognizant that it is a pattern and it's a transition pattern, ideally, in which most people will go on to an active form of treatment, but it does delay it. I've skipped through fairly quickly, but I'm really interested in questions. But I have one for you first. We've done a significant amount of work with prostate cancer support groups, and we've just completed a 3-year study. Is that? Thanks, Bob. I've brought these along today. I'm a huge fan of prostate cancer support groups, and I'll encourage you to take one of these home with you and have a read. We've done some good research around the efficacy of support groups. But my question relates to support groups, is that how might prostate cancer support groups support men who are on active surveillance? And that's the question I'd pose to you as starting off a dialogue, if we can.
What was the criteria for gaining on active surveillance?
Yeah, criteria. So it'll vary. Okay, so it'll vary between clinicians, and so these men under 10 in the PSA and under 6 in the Gleason score. And that was the evidence that, okay, this is confined, that the numbers correlated would suggest that the cancer is confined to the gland.
How about each?
Didn't come into it. No.
What was the question? What's the age?
The age, yeah. No, so the age wasn't particularly like a criteria there. No. I think maybe there's more sensitivity to younger men who are screened, in terms of thinking about active surveillance. Maybe there is. But there's not really, because it's kind of brand new, I guess there's not the data to sort of be able to say just yet whether that's the case.
The decision to go on active surveillance probably wouldn't be made on the basis of one PSA reading.
No. So the idea being that you follow it over time, certainly.
I mean, even when if somebody just shows up first time had a PSA
Yep.
reading it's 6.9 and like Gleason is 6.
Yep.
You wouldn't say go on active surveillance. You would want to see what it's doing 3 months from now, or what it had done 3 months prior.
Yep.
To see if it's rising rapidly or staying level or what before it, because that would be a good indicator.
Yeah, I agree. Your baseline, that you start with, and then you probably are 3 months out, and if it indicates a Gleason, then you've got a couple of numbers there to work with and looking at the trend. There's been whole lot of literature at the PSA velocity, the doubling time of the PSA, and I think that's one of the key markers that people are thinking about in terms of this as well. Yeah, so it's not just. I didn't mean to represent it as a single PSA plus a Gleason, therefore you go on to active surveillance. So I think there's a couple of interim steps with, follow-up PSAs to make sure that the numbers are reasonable.
Or ideally, the man would have had regular checkups, annual checkups,
Sure.
annual PSA.
Yep.
It was slowly rising, and suddenly get to a point that a biopsy was called for, and at that point, they say, okay, your PSA has been going up very slowly the last 3 years.
Yeah.
Now we've done it. Now we've found this. So active surveillance is a wonderful choice.
And that's nice evidence to think about the idea of being tested earlier. Because you have a longer stretch, a longer baseline to look at, and you look at the trend over a longer period of time. If you've started going at 45 or 40 or a little bit of the younger age, then you've got more data to work with.
How do you handle the question of the prospect of metastasis?
Yeah. It's I agree with you. It's a really difficult thing to do. That's part of the uncertainty for, I think, a lot of the guys was that exact thing. If it escapes the gland between these 6 monthly tests, and there's no way of knowing its growth time and how aggressive it is, I think that was one of the things that played on people's minds. Yeah, no, I agree. Good point.
I would think that active surveillance or watch and wait would be if a person's in his 40s or 50s. I was in my 50s, so I certainly wouldn't do the watch and wait, because I don't want to be scaring anybody, but it's every 6 months you don't know whether you're going to be around for the next 6 months. But it's for the person who's in their 70s and 80s, it's one of those things that if you've got a T1, T2 and a low Gleason score and so forth, you may do the thing that you're going to pass away with something else with prostate cancer.
Yeah, and
So I'm surprised the age thing didn't come up on the study.
Yeah, I think that, increasingly, I think the active surveillance watchful waiting piece is different. It's not just wordsmithing, but I think in those sort of scenarios, there might be some bleeding of the terms. If you have a man in his 9th decade who's got a raised PSA, then yeah, I agree. You know, you might continue to watch that. Is it really active surveillance or is it watchful waiting? I think it bleeds at that point. You know, and I don't think that's draped in the notion of curative intent with a treatment down the line. So I think that does become watchful waiting by definition, but there is some bleeding there for sure. Yeah, I agree. Yes?
Has there, maybe I missed it, but has there been any studies done that proves that diet and exercise has a positive effect on cancer, prostate cancer?
The literature that's coming out around exercise suggests there is a benefit, both in terms of a recurrence, reducing recurrence, and I think that relates to a few things. You know, in terms of just general health, well-being, often an older age group of men as well. So I think exercise is generally, you know, low impact, mild impact exercise is a good thing. Diet-wise, the science isn't quite there. There's a randomised control trial coming out of UBC that's looking at pomegranate juice, and there's been a few things. I think that there will be some dietary guidelines, and Sherry Van Patten out of UBC and the Cancer Agency has just come up with a little postcard for the groups in Vancouver to sort of guide them about ideas with diet, but most of it's kind of generic kind of material that talks to a healthy diet. The difficulty, I think, with some of the diet piece is that even if you found the magic, you know, type of ingredient, the micronutrient, it's very hard to enact that in people's daily lives, you know.
Well, I'll see how it works out because I'm watching my diet and I go to the YMCA 3 days a week for the last 10 years. So I'm hoping that it'll have some possibility.
Well, you look well.
Thank you.
How often were the PSAs taken, John, here?
So these every 6 months.
Every 6 months?
Typically. Yeah.
Wouldn't on a startup like that, wouldn't you want to be taking the PSA more often than that?
Yeah, well, these guys, you know, a few of them were under that 12-month mark.
Yeah.
And so, yeah, I guess your initial reading, and like what Bob's suggesting, take it at baseline and then bring back at 3 months and then drop into the 6 month piece. So when we encountered these guys, most of them were on the 6 months, but you know there was probably an interim of 0, 3 month, 6 month, 12 months. Yeah.
Do you set a goal? So when they say, okay, when you reach this PSA, you're going to start treatment, or when we reach this score, we're going to start treatment?
Interesting. Is a really good question. So the PSA would be monitored, but no absolute number. So the doubling time becomes important in that. And what these guys are getting is repeat biopsies. Now, and that's not, you know, I mean, that's not without consideration, you know. I mean, clearly invasive. It has its own set of risk factors around infection, you know, even impotence, you know, erectile dysfunction. So that's not without some thoughts. And in fact, one of the 46-year-old fellows in this had, I think it was 3 biopsies, and was very reluctant to have a 4th. You know, I mean, so it's a consideration. You know, we frame this as being non-invasive, active surveillance, but that is a true consideration in this for sure. It's something we really do have to think about. Yeah.
John, from what I have read and listened to, it seems that there is a consensus of focusing on doubling time of PSA.
Mm-hmm.
And it seemed that when it came down to 1 year, then it was time to take action. The other issue that I seem to be reading into what I'm hearing is that there is a shift, especially for younger men, to move towards a state-of-the-art MRI, or a color Doppler, CT scan, which will tell you much better whether the size of the tumor, where it is, and how close it is to the wall of the prostate.
Mm-hmm. Yeah, and you've got to hope that those technologies arrive soon and are accepted, clinically. I think there's still a predominance to want to look at a specimen under a microscope for a lot of people, and whether that's about inertia or whether that's about, the way we've always done it, I'm not sure, but it still seems to be the predominant way in which people are certain of a cancer. But I agree with you, a less invasive way of definitively diagnosing would be a real advantage. Yeah.
What was the MRI and what was the other one?
Color Doppler ultrasound or color Doppler CT scan.
Mm-hmm.
And color Doppler is measuring the speed at which blood vessels move. And close to a tumor, where you have a new blood supply to the tumor, then those blood vessels tend to be large in number, and the blood flows very fast. So with a Doppler system, they can tell how fast it is moving. And that's the technology.
Is that available anywhere?
It's available in the States.
That's not here.
It will cost. And of course, a younger man, he's got a lot at stake. And perhaps better that he invest in that than take a chance. You take an old person like myself, then you take a chance.
Or if you can't afford it, you take a chance.
Correct.
Yeah, well, cost is clearly another.
Fred, what's the cost on something like that in the States now? Do you know?
I would be totally guessing. Between one, no, I would say a couple of thoughts, just for a color Doppler system. For an MRI today here in town is about, I think, $700.
Yeah.
$750.
Yeah.
And the technology has improved so much in the last few years that yes, they can identify where the tumor is in the prostate, which is better. In my opinion, from the ultrasounds that I've seen, is light years ahead.
Would certainly help in terms of thinking about active surveillance as well, wouldn't it?
Exactly.
Yeah.
There's an area of active surveillance. I know several men who have a rising PSA, have gone through multiple biopsies, and have not been diagnosed with prostate cancer.
Mm-hmm.
But it's still a concern for them. They're still getting their checkups every 6 months.
And of course, the PSA can be responding to prostatitis, to benign growth. It can be, it can be a host of things. And similarly, I'm aware of men with benign growth who still have the biopsy to make sure it's not somehow become a cancer. Yeah.
I realize your presentation is really focusing on men's experiences.
Yeah.
You're not coming out saying this is the be all, the end. You're not promoting active surveillance. You're simply saying this is what guys who are on it are finding out, and this is what they're going through, these are the things they like and don't like, and everything else to do with it. I think that this early detection, this benchmark test at age 40, we can get guys to get that benchmark test and then get regular PSA checks. And as it progresses and it finally gets to the point where there's a biopsy, then this whole question of active surveillance becomes a very, very valuable procedure.
Yeah.
It's something that should be, if it's going up slowly over 10 years, suddenly you're diagnosed with cancer, well, you've got all the reasons in the world to go on active surveillance until doubles.
Yeah, I agree.
John, question for you. I fall into a different category of class of people that you've identified. First of all, the PSA was well above by several factors the numbers that would normally be talked about relative to active surveillance, and same for the Gleason score. I've gone on hormone therapy.
Yeah.
How would you structure your research to address some of the same questions, or would there be differences in the questions that you might ask of a group of men who had this advanced condition, some escape from the prostate gland and on the hormone therapy, but for whatever other reasons are not eligible, not presently in the position of looking at some of these other more active treatments?
If I were to interview you and talk with you, I'd ask you questions about your active surveillance, because I still see some of it as absolutely relevant to you, and I'd probably ask you a lot of questions about the hormone therapies and how that's playing out for you, and I'd look at your behaviours as well, because you might fit into one of those too. I do. Okay. And so I guess the difference in my questions for you would be around the treatment, the experience of the treatment, and how that's playing out in your active surveillance. Because I see a lot of fellas doing active surveillance who don't fit the medical definition that I've presented here tonight. Yeah.
But I'm wondering, then, you mentioned that the markers are indefinite relative to the active surveillance group.
Yeah.
So surely also indefinite relative to the group that I would be part of as well.
Yeah, so in terms of the measuring of that.
Measuring the significance of the numbers as opposed to the other conditions or the other treatments that we follow.
Yeah. And so typically the hormone therapies are kind of, there might be intermittent, there might be long-term, those sorts of things. But thereafter, I guess, in terms of thinking about options titrated to PSA levels, that would be an interesting question to ask, and some interesting data, I'm sure. And I haven't seen any.
I haven't seen any for those two different
No, I haven't. It's a very good question. Very good.
How does low-level cancer in prostate affect a man's health?
Ideally it doesn't. So ideally, if it's confined to the gland, ideally it doesn't. So, most times with the urinary symptoms, oftentimes we see them more often in benign growth because the growth is closer to the urethra. So often lateral is more kind of the cancerous. So I'd say if there was a low-grade cancer that you knew was just a little dot that was confined to the gland, I would hope that it wouldn't be affecting the health. Yeah, I'd be hoping.
Just a comment. Following my cancer surgery, I had an opportunity of doing a course on mindfulness with the Cancer Society. And it was phenomenal in terms of reducing stress and anxiety. But I look at my cancer journey, and some of the most difficult times were those early stages of waiting for the next test, waiting for the biopsy. Did any of the subjects in your study, were they ever involved in yoga or meditation or mind controlling programs that help reduce anxiety and tension, particularly in the early diagnostic stage?
Yeah, we have integrated healing in British Columbia, and there's often a fee attracted to that, so it's a user pay. And some of the guys were involved in that quite heavily in terms of meditation, different sort of things that we might think alternative, and cognitive retraining, like to retrain your thoughts about, when you're having that self-doubt and that uncertainty. And some of the guys did talk to us about that, yeah, for sure. Just a question for you. Did you think it should have happened earlier for you? Were you?
I think it would have been helpful right at the beginning.
Okay, good
it would have reduced some of the anxiety because I'd be anxious counting days, counting hours before I got test results or before going in for the test. Interestingly enough, I think I was the only one with prostate cancer in the group. A lot of them were in there with other cancers and some of the second, third cancer operations. And the cancer is very, oftentimes are much more severe and much more debilitating than what I went through.
And were there many men there?
No, there weren't. But it was probably because of the time of the class that I took.
I took the same thing about a year ago, and I had the same observation as you. I was the only guy there with prostate. I was the only man, and in fact, I had mentioned it to one of the directors here to contact the people to come give us a presentation.
Yeah.
And I found it an enormous help.
Mm-hmm. And it's a good point. I thank you for that, because I'll maybe raise that as something we should think about early on, sort of at the beginning of this.
Sorry, this guy over here, he was talking about active surveillance after a recurrence?
Okay, so I'm suggesting that some of the principles about active surveillance extend to everybody. If you've had a prostatectomy, if you've had brachytherapy, I think there's still that notion of looking at PSA scores, regardless of treatment modality, and some of these things still apply. So I wasn't positioning it next to my definition and what I've presented today, but in terms of generic, qualities and ideas.
Yeah. Your study was focused on men with the active surveillance, and you talked about sort of the observations and where they were coming from, but I either missed or you didn't talk about conclusions in terms of what were they missing? What did they feel they were missing that you could come back and say there was some actions that you or other professionals should take?
Excellent. Thank you. Thank you for that. So, we did a needs analysis with the guys, the 25 guys. I'm glad you mentioned it. I often forget things. And nothing. There was just nothing. There was nothing they needed. So it was being handled in-house. Regardless of the kind of predominant behaviour that we saw, there was nothing that they could come up with that would help them. Well, and it's interesting, isn't it? So psychosocial kind of supports that we were thinking about, they weren't. But I would argue that puts the onus back on the healthcare professionals to not accept that, but to make it accessible, engaging, bring people into it, because often people don't actually know necessarily what they need, perhaps, or So it was very interesting for us because we kind of got to dream this stuff up and hope that we can bring people into it. But the needs analysis was like zero. It's very interesting.
My first reaction to that is there's a little bit of denial going on there in order for them to see that.
Yeah, and so those guys who are committed to living a normal life, as I put it, that's why I think, I wonder whether the back door is to start just talking about health, just trying to get some general health knowledge in there as a way forward. Just to engage them at some level and make sure you don't lose them to follow up. Because my concern is that ultimately you bracket enough that you don't have it, right? Yeah, so interesting. Yeah.
You asked a question when you started.
Yes.
How can support groups support people on active surveillance? It's my opinion that people who are on active surveillance need to be drawn out of the woodwork. And this as a modality has to be given recognition as a bona fide way to treat cancer. And most people go directly to active treatment. It may be that a group, such as we have an advanced group here, an active surveillance group, would allow people to get around the table and share their experiences and be able to say to each other, this is a normal way to go, that we're not off the wall doing not treating our cancer. And they would learn a number of things. For example, in Japan, I believe, correct me if I'm wrong, that over 50% of people go on an active surveillance modality, and they go on to hormone therapy to try to put off the eventual day when they have to take action.
How many of these people that were in your study, particularly the ones that wanted to live normally, were given information like this mindfulness Cancer Society endeavor, so that they would understand what it was, or were they blocking all that out because I want to live normally until I have to go to the hospital?
Yeah. So opportunity is made directly after the consult, to come into the prostate centre and be given information. But of course that's optional. So there's a degree of blocking there, for sure, in terms of, not necessarily needing that information or wanting that information. That's definitely one of the issues, I guess, in terms of the blocking. And so how you make that available and how you start that dialogue seems to be incredibly important, about somehow finding a way forward for those fellows. Yeah.
You people in UBC there, your people are developing stem cell research. And I don't know whether you ran out of mice or not, but how is that going to affect the prostate advancement there?
Honest, I know that there is research going on around that area, and I know it, but I'm not privy to what sort of level it's at and what the economics around it are. So yeah, I really can't give you an answer, and I'm sorry I can't. But I'm not really entirely sure what the economic situation will mean for that. Yeah, to be honest. Yeah.
Any more questions? It's okay. It's got a few more minutes. Good. John, before you go away.